All right, let's go ahead and get started. Good morning. Welcome back. I'm John Hickman, one of the chief residents of internal medicine, and it is my pleasure to welcome you again to Grand Rounds for the Department of Medicine at Washington University School of Medicine. On behalf of our chair, Dr. Frazier, Drs. Costco, Spencer, and myself, we're so glad you're here and to have you join us to help celebrate our Global Health Week. As a reminder, at the end of the talk, please send questions via the Q&A function as we go, which I will moderate with our speaker later in the talk. There is also an opportunity to meet with our speaker in another Zoom meeting immediately following Grand Rounds this morning, which is very exciting. So look out for a link in the chat for that. Here to present our speaker is Dr. Davila. Dr. Davila is a professor not only of medicine, but anesthesiology and radiology. He serves as the medical director of the Cardiovascular Imaging and Clinical Research Core Laboratory and the director of our Global Health Center. Dr. Davila?
Thank you so much, John. Good morning, everybody. It is a great pleasure for me to introduce our Department of Medicine Grand Rounds speaker, Dr. Mark Hoffman, as part of our Global Health Week at Washington University. Mark is a cardiologist whose research program spans the spectrum of cardiovascular disease prevention and control, ranging from food policy to polypill therapy. He has expertise in clinical trials, implementation research, health systems, and health policy research. His global health research activities include multilateral projects such as comparing sodium policies in Nigeria and China, and testing polypill therapy in the US, Australia, India, and Nigeria. He is a principal investigator on several NHLBI-funded research and training projects in low and middle-income countries such as India and Nigeria. He is also PI on an NHLBI-funded study in Chicago, where they're looking at multi-level implementation strategies to improve cardiovascular health and healthcare, including a novel 4-in-1 water dose combination polypill for blood pressure lowering. Mark is a founding member of the Science of Implementation in Health and Healthcare Study section at NIH and chairs the NHLBI Global Alliance for Chronic Disease 2.0 Steering Committee. He has published over 215 peer-reviewed manuscripts. Recently, we have been lucky to recruit Mark to join our cardiovascular division in the Department of Medicine at WashU as Professor of Medicine, when he will start on January 2022. He will also be the co-director of our Global Health Center in the Department of Medicine. Mark and I have been working to develop our global health strategic vision to enhance clinical research, education, mentoring, and faculty development to promote a robust interdisciplinary global health program. He brings unique skills and leadership that will greatly enhance our program. Today, Mark will be giving Grand Rounds presentation titled Global Cardiovascular Health in the Peri-Pandemic Era. Please join me in welcoming Mark Hoffman to Washington University in St. Louis. Welcome, Mark.
Thank you very much, Victor, and thanks, John, for your introductions. I'm so excited to be here with you today. I wish I was with you in person, but look forward to joining just in a couple of months. I'm going to need your help because this is a big problem. We're talking about global cardiovascular health, global cardiovascular disease. And in this peri-pandemic era, everything has been upended. And the way in which we think about the world has changed fundamentally for all of us in some way. So moving forward, the challenge will be how will we improve global cardiovascular health and healthcare? So these are my disclosures. I think the most relevant are related to combination therapy. I have 2 patents pending for heart failure polypills, as well as work at the Georgia Institute for Global Health, which has received investments for commercialization of polypills. The UN Sustainable Development Goals really provide a framework for priorities for global collaboration. Shown here on the left, the one most relevant to us in medicine is good health and well-being with the scariest EKG we've ever seen. But we're trying to ensure healthy lives and promote well-being for all at all ages. Now, a specific target to non-communicable diseases, including cardiovascular diseases, is 3.4. By 2030, to reduce by 1/3 premature mortality from non-communicable diseases through prevention prevention and treatment and promote mental health and well-being. Well, there's about 19 million deaths due to cardiovascular diseases every year, about 1 out of every 3 global deaths, including during the pandemic. There's related targets, though, that think about how this is going to happen. And achieving universal health coverage is actually part of target 3.8, which we don't really have in the United States. And this includes things like financial risk protection, which I'm going to talk about, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. These are really topical during the pandemic and will continue to be after the pandemic. So where do we stand in terms of trends in global cardiovascular disease deaths? These are data from the Global Burden of Disease Project. This is led by Greg Roth. On the left-hand panel, we see from 1990 to 2019, female and male sex deaths due to cardiovascular diseases over the past almost 30 years. So it's been increasing to, again, about that 19 million overall. And we see this clubbed together in both sexes in this panel here. But down here, we have the deaths per 100,000. So the blue is age standardized. So we've been seeing actually a decline over this whole period, but the deaths per 100,000 has been flattened. So essentially, this overall growth that we're seeing up here is driven largely by population growth and aging. So even though the age standardized rate has been declining globally, there's still an increase in the overall burden of cardiovascular disease deaths. But in places like the United States over the past decade, we've actually been about flat, starting to go up in our age-adjusted rates. So this is a big problem. Now, there's a lot of heterogeneity across time and space. So this is the spatial heterogeneity. We see hot pockets in places like South Asia, places in Africa, and even in different countries in Latin America and states in the United States. So all is not even throughout the world in terms of the trends in cardiovascular disease death rates. Now, these are data that are looking at the trends in risk factors that are modifiable over a similar time period. So systolic blood pressure continues to be the dominant driver, number one, followed by dietary risks, HDL cholesterol, and air pollution. Fortunately, tobacco consumption has had a modest decline over the years, but what's the countervailing factor? It's high body mass index. So we're starting to see the effects of obesity, where no country in the world has been able to curb the obesity epidemic thus far. So we're going to need some transformative approaches to be able to improve cardiovascular health globally. This paper by Chris Murray last year tried to summarize what's happening over time for the different risk factors. So as I mentioned, high body mass index is rising, as is air pollution, high blood pressure, high glucose, and alcohol use. This is for all non-communicable diseases. Declining, though, is tobacco, solid fuel household air pollution, and child growth failure. Dietary is mixed, so we're having an improvement in undernutrition, but a worsening of overnutrition. But health systems are not ready to face the rising burden of non-communicable diseases, including cardiovascular diseases. The panel on the left shows sociodemographic index on the x-axis and average universal health coverage, effective coverage index. Essentially, how well is coverage being observed in different countries? The red dots represent communicable, maternal, neonatal, and nutritional conditions, and the blue dots represent non-communicable diseases. So this graph shows that for non-communicable diseases, despite increases in sociodemographic index, there is not a commensurate increase in the average UHC effective coverage. So health systems need to catch up. They need to be able to invest more in non-communicable diseases, not at the expense of CMN diseases, but really in addition to. These are investments that need to be made. Now, I think that working across the entire spectrum of heart disease prevention is critical to having a comprehensive and cohesive approach. We know what the playbook is. We've seen it from a decline in heart disease deaths from 1968, the peak in the United States, till around 2010. It's following these key approaches. So for tertiary prevention or acute care, these are for people who are having acute cardiovascular disease events. We need global hospital-based quality improvement programs using real-time data and training. And the goal is for equitable access to optimal care throughout the chain of survival. Now, this approach would have the largest gains in the shortest time. So think about if you, in days when there was much more travel than there is now, if you have a heart attack in St. Louis or Chicago, or places where I work, like in India or Nigeria, what is the level of care that you will receive? Ideally, people in all parts of the world are receiving high quality care throughout the chain of survival. Next, we think about people who have survived a cardiovascular disease event, what's known as secondary prevention, or then we also have people who might be at high risk for a cardiovascular disease event or high risk primary prevention. In this group, think about there's all kinds of data that are collected on a regular basis, whether it be risk factor data, genomic data, imaging data, and we need to leverage that for discovery. I've been interested in working in South Asia for a long time, in part because of the predilection that South Asians seem to have for developing atherosclerosis. There's something there probably that's going to be good for all of us. We need to have global research platforms for large, simple trials that use common protocols so that we can translate evidence-based interventions into routine practice more quickly. But we also need to simplify treatment and self-care with mobile technology, polypills, virtual clinics, pharmacy-based care, and community health workers. The goal is to match the most effective and scalable interventions to patients' needs, meet them where they are, not where we are. And this will have the largest population, this will address the largest population at risk over the next decade. And then lastly, this primordial prevention, or the prevention of risk factor development in the first place. And this is for people who aren't even thinking about cardiovascular disease, such as kids and adolescents. And here we need surveillance systems of the global packaged food supply to improve and transform the way in which food is produced, manufactured, distributed, marketed, consumed. And we need to achieve tobacco endgame. Tobacco continues to be a major driver of poor health, not just cardiovascular diseases, but think of cancers and lung disease and so on. And the goal is to improve the healthfulness of the food supply and to completely denormalize tobacco, so less than 5% of the world's population consumes it. And this will have the largest overall effect over the longest time. Now, it's medicine grand rounds, got to talk about a case. So I want you to, this was in the emergency department a few years ago, and I was consulted for chest pain. The history of present illness is a 61-year-old Hindi-speaking South Asian male presented with accelerating angina while visiting Chicago from Delhi, India. He has a history of asthma for which he takes bronchodilators and had increasing dyspnea on exertion and angina over the past month. He'd been in Chicago for about 6 weeks. EMS was called and symptoms improved with sublingual nitroglycerin. Because of his really high blood pressure that you'll note on his exam below, he had a CT angiogram that was negative for PE and acute aortopathy, but he was noticed to have 3-vessel coronary artery calcification. He was afebrile. His blood pressure was 205 over 99. 98 beats per minute was his heart rate. 18 breaths per minute was his respiratory rate. And he was setting fine on room air. He was tearful when I came to speak with him. And I was asked to come see him because of the recommendation for angiography. And he was declining and deferring that. He was tearful because he was concerned about how much it would cost him to have this procedure. And he's asking me how much it will cost. And like many of you, it's very difficult for us to be able to answer that question. We don't always know what the costs of certain procedures will be, which is interesting, right? That caused a big problem because of the financial risk protection that we talked about earlier. This is happening in Chicago, but it's also happening in India and around the world. So he was not congested. He had a 2 out of 6 aortic stenosis murmur. He did not have an S3 and his lungs were clear. His troponins were modestly elevated. This was pre-high sensitivity troponin. His creatinine was normal. His LDL was only 96 and his hemoglobin A1C was 5.9. Here's his electrocardiogram that shows sinus rhythm with infralateral ST depressions. And then he starts to have some evidence of potential elevations in AVR. So we had a long discussion about what we were trying to do, what was the rationale for a diagnostic coronary angiogram and potentially coronary stenting at the same time. And because I had done research on microeconomic or individual and household level costs in India, I was explaining to him that this is a problem not just in Chicago, but also if you were to go back home. And ultimately, he was amenable to pursuing angiography, as we talked about this. Now, his left heart cath showed a proximal hazy 80 to 90% stenosis, and this was his culprit lesion. He had some other disease, including 100% chronic total occlusion of his right coronary artery with left to right collaterals. So he did receive a single drug-eluting coronary stent to his proximal left anterior descending artery. And for discharge, we discharged him on guideline-directed medical therapy with dual antiplatelet therapy, a high-intensity statin, beta blocker, and a RAS blocker. And I referred him to a colleague of mine in Delhi at the All India Institute for Medical Sciences for secondary prevention of cardiovascular diseases. So this is a patient who is a visitor. And we think about patients who don't seek care because of their fear of what the costs will be. We think about immigrants or undocumented individuals in our communities who don't want to come to our health facilities because they're concerned that there may be other ramifications. Instead of health being a human right, often we treat it as a commodity, and that's not going to achieve improved health and well-being for all will. So I want to talk a little bit about some of the work that I've done in this tertiary prevention or acute care setting in India that's relevant to our case. So I helped lead the acute coronary syndrome quality improvement in Kerala, or ACS Quick clinical trial. This was with support from NHLBI in collaboration with the Center for Chronic Disease Control and the Cardiological Society of India Kerala chapter. We worked across 63 hospitals and recruited more than 21,000 patients. This is the largest cardiovascular randomized trial performed in India to date. And the PCOTs for this is really, we were identifying patients with acute myocardial infarction who were admitted to participating sites. And the intervention was a multifaceted, adapted quality improvement toolkit based upon the American Heart Association's Get the Guidelines program for acute MI. This included audit and feedback, checklists, patient education materials, and linkage to provider training for ACLS care. The comparator group was usual care using a step wedge design, and their primary outcome was the composite of death, reinfarction, stroke, and major gusto bleeding. Secondary outcomes included the individual MACE components, health-related quality of life, microeconomic costs, and a process evaluation. We looked at these outcomes over 30 days and performed the study in Kerala, India, as I said, using a step wedge cluster randomized trial design, where all hospitals started out in the control period, all ended up in the intervention period, and is at predefined steps where hospitals randomly selected to move from the control to the intervention in a one-way crossover design. This allows us to account for temporal trends and allows us to ensure that hospitals are able to receive the intervention throughout the study. So these are the primary results that show on the y-axis 30-day MACE, and on the x-axis is each of the steps. The control hospitals are shown in gray and the intervention shown in red. And so the unadjusted 30-day MACE rates were 6.4% in the control and 5.3% in the intervention group. So you think, hey, this is really great. Yeah, got a 1.1% difference. But if you look at the slope of the control MACE rates, we start to see them going down. And we also start to see things coming up in the intervention period. So we have a reduction in some of the variance, which is generally considered quite good. But when we do the cluster adjusted and cluster time adjusted, we see an abrogation of that effect, where there was no difference in 30-day MACE after adjusting for these. We start to see a signal of this, of 30-day death in just the cluster adjusted models. But by accounting for time, things are changing in places like Kerala, where the outcomes are really similar to what we observe in the United States. 5.3%, like, wow, that's pretty good. In terms of GDMT, there was an increase overall in hospital and discharge GDMT. So the process of care measures improved, as has been observed in other trials, but we were not able to observe an improvement in outcomes, largely because they were so good. And so one of the messages is the balance of working in a place like Kerala, where there was a lot of organization, a lot of enthusiasm, but when the quality of care is already quite good, it's hard to improve upon that. Now, remember our patient who is concerned about costs. Now, I want to compare what the out-of-pocket costs for cardiovascular diseases are in the United States on the left and in India on the right. So these are from the NHIS data from 2013 and 2017. These are outpatients with atherosclerotic cardiovascular disease with an age range of 18 to 64, because out-of-pocket costs for 65 and above in the US are obviously much different because of Medicare. So this cost individuals almost $3,000 per month. 88% of these individuals were insured, but still 45% had some financial hardship from medical bills. And 19% of Americans were unable to pay for their medical bills. So clearly the system that we have in the US isn't working in terms of financial risk protection. In terms of ACS quick data, these were collected between 2014 and 2016. And this was the month following their acute myocardial infarction. These individuals were generally older, and their income was about $525 international dollars, kind of normalized across time and space. So much lower income, only 24% were insured, and their out-of-pocket costs were $374. So about half of them had what's known as catastrophic health spending, meaning they're spending 40% or more, that was the definition we used, on health expenditures after taking rent and food. And this is likely to push people into poverty if sustained over time. 8% has what was known as distress financing, meaning they took a loan out or sold assets to be able to cover their medical costs. So we know taking care of patients that the dollars and cents matter for them. And if we don't have a system that allows risk pooling and essentially prepayment through that, we're going to face a lot more catastrophic health spending, not just places like in the US and in India, but around the world, where insurance is generally limited to high income countries. Now, these are data broken down from our microeconomic study. And these are just for people who are presenting to a private hospital. And these are the in-hospital costs over here and the post-discharge or after hospital costs. And we can see the largest is treatment. And this is really for stenting. And so the world in which we live is, practice isn't in a vacuum, right? So just around about a year after we collected these data, the Indian government actually put a cap on stenting to try and drive cardiologists to be using stents that were made in India. So we think about this crosstalk of like the work that we do clinically with the system and the larger policies, and how we can mitigate some of these financial risks as well as health risks for our patients. So the work that I've done with the Cardiological Society of India has been fabulous. I've really enjoyed working with them. And part of it is that they're continuing to have a research infrastructure. So Giver Zakaria led this paper earlier this year that was looking at myocardial infarction admissions in India before and during the early days of the COVID pandemic. So these are two figures looking at weekly MI admissions per state on the left-hand y-axis. And then on the right-hand is the cumulative COVID-19 cases. The bottom panel, it's the same sort of left-hand y-axis, but on the right, it's really the lockdown index. And what we're seeing on the x-axis is time, and we have MI admissions in 2020 in blue, MI admissions in 2019 in orange, and then the COVID-related factors in red. So, over this period, there's more than 41,000 MI cases from 187 hospitals. So demonstrating the ability to collaborate, not just in Kerala, but throughout all of India. And so this is that network approach that I think is really important to be able to start to do, large scale research. And Giver and colleagues observed that MI admissions were more strongly correlated with lockdown index shown on the bottom panel than with COVID cases, and with an R-squared of 0.95. So people were definitely staying away from the hospital associated with lockdowns in India. And this has been observed in other settings as well. And what I think is that this also demonstrates the sustainability and growth of research that's led by the Cardiological Society of India. And professional organizations are a potential way to engage in global health research that allows things to be scaled up more than just on a one-on-one, institution by institution basis. Ami Banerjee from University College London has also looked at the direct and indirect effects of COVID on CVD. And he did this really using some of the unique data that are available in England. And it's really few places really have the requisite clinical and public health data linkage. Think us in the US, we were definitely caught flat-footed because we couldn't link what was happening within the hospitals and the public health sector together to have a understanding. It took a while to really build that up. If you think in the past decade, building out EHRs throughout the country, it didn't have that public health link like is done in England and a few other parts of the world. Now, what we have is these excess deaths in individuals with cardiovascular disease. First, there's just the baseline risk based upon what the CVD is, age, sex, comorbidities, and so on. Then there's population infection rates ranging from 10 to 40 to 80%, and thinking about what's the relative impact of COVID-19. So there's the direct effects of COVID on CVD and based upon hazard ratios ranging from 1.2 to 3.0, but then also the indirect effects of COVID-19 on CVD mortality. And these indirect effects are things like not being treated for your high blood pressure, not being treated for your angina. And those indirect effects are going to be delayed rather than contemporaneous. So he estimates anywhere from 81,000 to more than 160,000 excess deaths in individuals with cardiovascular disease in England due to COVID-19. So pretty substantial effects, and I want you to really think about the direct and the indirect. This figure is looking at really time overall, where again, the green here shows the lockdown. We have the outbreak in black, lockdown in green, and ease of lockdown. And we're seeing the excess total of deaths in blue, the excess non-COVID deaths in green, and the excess CVD deaths in this kind of darker blue. So overall, this kind of big jump here in the context of these different time periods related to what's happening in the lockdown. Okay, so we've been talking about tertiary prevention. So next I want to give a couple examples of secondary and primary prevention, talking about polypills and community health workers. So these are data from the polypill trialist collaboration that I'm a part of. This is a paper Phil Joseph led earlier in the Lancet and published simultaneously with the European Society of Cardiology meeting. And the left-hand panel shows across 3 trials in 25 countries and more than 18,000 participants, the cumulative event curve of a fixed dose combination or polypill strategy in red with the control shown in blue. So the hazard ratio is 0.62 for major adverse cardiovascular events. So polypills reduce MACE by more than 1/3. Now this is despite lower than expected risk factor changes with the components. So that's really accounting for things like non-adherence, for example. So an LDL cholesterol reduction of 23 milligrams per deciliter and a systolic blood pressure reduction of less than 5 millimeters of mercury shown on the bottom panel. Now this risk reduction with a scale of it was observed in polypills both with and without aspirin when thinking about primary versus secondary prevention. Dizziness was more common, as was GI bleeding, though relatively uncommon in the polypill group. So this idea of polypill for all that had been posited by Walden Law back in 2003, not the right strategy. There does need to be some risk stratification to identify individuals who are more likely to benefit, but polypills have a substantial effect on reducing the risk of major adverse cardiovascular events and are generally safe. So these are really unique data that I think will be useful in moving the polypill agenda forward. Next, talking about hypertension and how we're going to use community health workers, including in St. Louis, for improving the treatment and control. So this is a paper from the NCD risk collaboration, and this is showing for women only. So the goal is how to close the gap for more than 1 billion adults globally who have hypertension. And these are various cascades of care that are looking at individuals who aren't even diagnosed. So all women worldwide, it's about 41% who aren't even diagnosed. So without being diagnosed, you're not going to get treated. You're not going to have your blood pressure controlled. And then through each step of the cascade, you can see there's a drop off of those who are not treated, those who are treated but not controlled, and only 23% of women worldwide with hypertension have their hypertension controlled. Wow, that's a system that is clearly not working. And you can see the differences across different income countries. So high income Western is 43%, whereas places like Oceania and Sub-Saharan Africa, 12 to 13% control rates. So a lot of variability, meaning that there can be improvements with the right strategies. Now, the work that we've been doing in Nigeria, which is the largest Black country in the world with more than 220 million individuals, shows that the prevalence of hypertension in adults greater than 40 is about 45%. So it's really high in this older age group. Now, if we look across all adults, it's about 29%. Based upon a 2015 systematic review and meta-analysis. Either estimate represents a major public health burden, yet hypertension awareness, treatment, and control rates are very low in Nigeria. So what we've done is through a type 2 hybrid study that's funded by the National Heart, Lung, and Blood Institute, have been adapting the Kaiser Permanente Northern California model, which is also part of the WHO Hearts technical package, to integrate hypertensive services into public primary care settings in Nigeria. I work with Dr. DK Oji at the University of Abuja on this project. And the multi-level interventions include a standard treatment protocol that's been agreed, that's at the national level. Second was we perform patient registration and empanelment, so calling people back when they're not coming for their follow-up. This is a health system level approach. We prioritize fixed dose combination therapy, generally 2-drug therapy, as a health system level intervention to improve the speed and reduce inertia that's observed for treatment of hypertension. There's team-based care, that's a health worker level intervention. So community health extension workers are empowered in Nigeria to be able to prescribe medicines according to the treatment protocol. Our formative work showed that they were already doing this. They wanted to do this. Hypertension was perceived to be a large problem by patients and healthcare providers alike. And so it's obviously not going to be feasible to have doctors to be able to take care of all patients in Nigeria with hypertension. There's simply not enough doctors, and it will take too long to be able to train all the doctors. There should be more training of doctors, definitely. Meanwhile, the community healthcare workers are a good strategy. And then actually right now, we're just starting to implement home blood pressure monitoring and health coaching on a patient level intervention. So we have been providing blood pressure lowering medications since December of 2020. And what we're doing is what's known as a drug revolving fund, where individuals pay a little bit over the market rate, like a wholesale rate, to be able to get a reliable supply of quality medicines to be able to treat their hypertension. We developed this pre-COVID. The plan was for community insurance to cover hypertensive services, but that's changed. So we have to change with the activities on the ground. So over the past, short of two years, we've recruited more than 13,000 patients from 60 public primary care centers in the Federal Capital Territory. We've had about 50,000 visits, and almost half of these individuals are newly diagnosed. So this is the largest hypertension program in Africa. For the baseline visits, or people the first time they show up, the mean age is 48.5 years. As above, about 2/3 are female. So we need to figure out how do we get more men to be able to come to primary care, which has been previously organized around maternal and child health needs. We repeatedly take blood pressures. So these are the second systolic and diastolic blood pressures, so 152 or 95. So people who have sustained hypertension. And the treatment rate, this is really the walk-out treatment rate. And this is a point that we're having a hard time figuring out. Think about all the times you have to do med reconciliation and figuring out the stop date of medicines. So that is a number that I'm not 100% sure about, but I'm definitely sure about the 13.5% control. So over time, we started in January and really started kick off in February. And February was when the first COVID cases in Nigeria were reported. We can see a reduction in the mean systolic and diastolic blood pressures from 149/91 down to 136/85.7 in August of 2021. Our control rates have increased from 13.5, 21.1, and now they're close to 47.7 in our sort of latest data. Now, if we look at this from the lens of the patient, like who's walking through and having multiple visits, these are different than repeated cross-sectional looks at the registry. So in the longitudinal analyses, the blood pressure reduces from 152/94.9 to 129.6/81. So there are definitely patient level factors that are driving the differences between these two. These people are different. And the control rate in this group increases from 13.5% to 64.5%. And I'm convinced that understanding how to improve retention and care is going to be critical, because there's a big difference in the blood pressures of people who don't come back compared to those who do come back. And if we don't reach the hardly reached, we're not doing the full job that we need to do to be able to improve cardiovascular health for all. So these are some photos of our study team in action. This is the development of the hypertension protocol on the left, with DK in the suit on the left. Dry blood spot sample collection. This was a sub-study that we did evaluating the seroprevalence of IgG antibodies to SARS-CoV-2 using a dried blood spot assay. It's about 71% as of December 2020 among primary care healthcare workers, really high. And then qualitative research training with Grace, Eugenia, and Tunde shown there. Now, what I think is pretty exciting is the potential for harmonizing global T4 translation hypertension research. The NHLBI has invested more than $50 million in hypertension programs in low and middle income countries through these different mechanisms in different countries. And you can see the different foci of the different mechanisms, but it's a lot of money that's been invested. And what I'm really excited about for coming to WashU is to work with people like Victor, Lisa de Fuentes, Alvin Gang, and so on. You see the asterisks are for projects that are co-led by WashU faculty. So if we can harmonize the data that we're collecting in Nigeria with all of these other data, it's going to allow us to be able to understand what are the strategies that will be able to be most effective at reaching people who need hypertensive services. And we think about the work is relevant to what we do in the US. I'm part of a project that takes the work we're doing in Nigeria and brings it actually back to the south and west sides of Chicago through something called the Decipher program. So some of the big questions as we think about improving global hypertension control efficiency to treat as many as some suggest maybe as 1.4 billion adults have hypertension. So the challenge is that we've got about 500 billion tablets for one drug for 1 year. So that's 365 times 1.4. It's about 500 billion. But most people need 2 to 3 drugs. If you think about the SPRINT trial. So we're talking about 1.5 trillion tablets need to fly around the world and end up in people's mouths every day. Now, what we need are more and simpler blood pressure cuffs, more health workers, major investments in information systems, and bigger, stronger, faster supply chains. And combination therapy is one of the many interventions but it's usually considered on the patient level, like it's going to improve adherence and those sorts of things, but no intervention can reduce the number of pills needed by half or more. So I've been lucky to work with Abdul Salam at the Georgia Institute, who's done a number of systematic reviews looking at the effects of different combination therapies so this is one on 2-drug fixed dose combination versus monotherapy. Been 33 trials and more than 13,000 participants. And the interventions are looking at different 2-drug combinations, like less than 1 standard dose. So you think of like amlodipine 2.5 versus 1 plus 1 of standard doses compared with standard dose monotherapy. And not surprisingly, you see a stepped increase in the blood pressure lowering differences. So for systolic blood pressure, 2.8, 4.6, 7.5. And the hypertension control rates also go up. Now, the withdrawal rates due to adverse events are modestly higher in in patients taking combination therapy. So this is the, the trade-off, right? Of how much efficacy and effectiveness versus what the potential side effects might be. Patients obviously and doctors are very interested in tolerability. So lower doses may be the strategy there. This is a paper that Ivor Benjamin published in The Lancet a few years ago, highlighting the inclusion of fixed dose combination therapy that Salam led, and I was a part of, to the WHO's model list of essential medicines. This is one strategy. It's not a cure-all. Polypills and medicines like this will be a component, but we need multi-level strategies, health workers to implement them, to make the diagnosis. We need information systems to track this, and so on. But this was an important milestone, and we've been trying to get combination therapy added to the WHO's model list for several years. Salam followed up that previous systematic review with another on 3-drug fixed-dose combination therapy versus 2-drug fixed-dose combination therapy. And here the mean baseline blood pressure is higher, and the mean systolic and diastolic blood pressure is about 5.4 over 3.2. So an increase in the control rate by 33% with a similar withdrawal rate due to adverse events. So taking this step a little bit further, 2 drugs, 3 drugs, 4 drugs. So Clara Chow, who's an investigator at the University of Sydney, led the Quartet trial published in The Lancet earlier this year that studied 591 adults with mild to moderate hypertension and gave them the combination. They were randomized to receive the combination of irbesartan, amlodipine, indapamide, and bisoprolol, but at very low doses, quarter doses, compared with irbesartan, which is a well-tolerated ARB at a standard dose. And the primary outcome was the change in systolic blood pressure at 12 weeks. The figure on the right shows the visit months on the x-axis. There was a 12-month follow-up for some of the participants, and then the difference in systolic blood pressure between the monotherapy in red and the quad pill in blue. So at 12 weeks, there was a 6.9 millimeter mercury difference in systolic blood pressure that was sustained over the 12 months to even greater at 7.7. And there was a modest increase in treatment withdrawal due to adverse events or side effects, 4.0% in the intervention versus 2.4 in the control. We're doing a parallel trial called Quartet USA using the similar combination in federally qualified health centers in Chicago, because there was, this was about 85% white or East Asian in this trial, and our trial is largely Hispanic and Black American. So really trying to take this idea further about more drugs, but at lower doses, may be a strategy for greater tolerability. Okay, so then we've been talking about tertiary, secondary, primary. Let's talk about primordial. So the most radical, like how do we prevent risk factors from ever developing in the first place? And I'll talk a little bit about some of the work we've been doing on food policy. So anybody who's interested in global cardiovascular health research really should be aware of the WHO's best buys for NCDs. There's other work like the Disease Control Priorities Project that looks at cost effectiveness and priority interventions. There's a roadmap out there for doing a lot of this work. And I would challenge most people to say, you should be working in this, and if not, why not? It should be something really novel. So these best buys are 88 cost-effective interventions, but 16 that are highly cost-effective, meaning their cost-effectiveness ratio is less than $100 per disability adjusted life year. And polypills or multi-drug treatment is the only health system response that fits into that category. So that's sort of that one piece. But we have others related to diet, such as reformulation of packaged foods, institutional policies, mass media campaigns, and front of pack labeling for diet, particularly as it relates to dietary sodium intake. For tobacco, the WHO's Empower package outlines things like tobacco taxes, plain packaging and warning labels, advertising restrictions, smoking bans, and mass media campaigns. And this has been implemented through the Framework Convention on Tobacco Control and has been one of the highlights really of global cardiovascular health over the past few decades because of the reduction in tobacco consumption globally. Physical activity, it's really around mass media campaigns and healthy environments. For alcohol, taxes, advertising restrictions, and sales restrictions can reduce the consumption of unhealthy alcohol use. And then cancer prevention is really around HPV vaccination and cervical cancer screening. Now, despite having a roadmap on what to do, this paper by Allen and colleagues a few years ago outlined that how few studies have looked at implementing and evaluating WHO best buys in low and middle income countries. So of the studies, the 36 studies, most of them were related to tobacco-related policies. So as I said, the Empower package by the WHO is a great roadmap for tobacco policy research. But most of these best buys haven't been studied, and most of the studies have not been performed in low income or lower middle income countries. And so about half of the best buys did not have good evidence from low and low middle income countries. So there's a lot of opportunities out there for people to be exploring how these could be adapted and implemented and evaluated. So related to sodium, this is some of the work that we've been doing with the George Institute for Global Health and the University of Abuja. These are the key strategies outlined by the WHO best buys. So one is reduce salt intake through the reformulation of food products to contain less salt and the setting of target levels for the amount of salt in foods and meals. Two is reduce salt intake through the establishment of supportive environments in public institutions such as hospitals, schools, workplaces, and nursing homes to enable lower sodium options to be provided. Three is reduce salt intake through behavior change, communication, and mass media. And four is reducing salt intake through the implementation of front of pack labeling. So this is a figure from the University of North Carolina that looks at some of the, for food labeling, for example. So these are the countries with mandatory food labeling shown in red and voluntary shown in orange. So NAVDAC, which is the Nigeria Agency for Food and Drug Administration and Control, has been really a vanguard of trying to improve the healthfulness of the food supply, including related to voluntary labeling. You can see some of the black octagons in parts of Latin America. These are warning labels, actually, where Latin America has been the leader. Warning labels definitely reduce purchases and thus consumption of less healthy foods. And that's been something many in the food industry have been fighting, much like warning labels we see in tobacco products. We've done some work trying to identify the salt reduction initiatives in Africa. And there's actually been pretty limited work. Only 12 have measured dietary intake, 11 measured knowledge, 11 measured salt in foods. 3 of them modeled health gains and costs of sodium reduction programs. 1 evaluated effects of a behavior change intervention. None have used an implementation research framework. And only South Africa and Mauritius had national sodium reduction policies at the time of this our search. Nigeria has subsequently created the National Multi-Sectoral Action Plan for the prevention and control of non-communicable diseases that includes some salt policies. So what we've proposed to do with the support from the NHLBI is to evaluate implementation of the WHO's SHAKE package. So SHAKE is essentially the technical manual to implement those best buys that we talked about. This was developed in partnership with the George Institute, which is a WHO collaborating center on salt reduction. And this work that we're doing in Nigeria is actually parallels work that's being led in China as well. So trying to think about how do we do multi-country studies. And SHAKE stands for surveillance, so understanding, measuring and monitoring salt use. H is harnessing the industry to promote reformulation. A is adopting standards for labeling and marketing. K is really knowledge related to education and communication. And environment is supportive environments to promote healthy eating. So we are conducting a type 3 hybrid study that's really evaluating implementation strategies using repeated cross-sectional stakeholder interviews, food retail surveys, and population surveys. Essentially, we use implementation frameworks like the Consolidated Framework for Implementation Research, or CFR, and RE-AIM measures that look at the reach, effectiveness, adoption, implementation, and maintenance. Food retail surveys are really using an app called Food Switch that's been used in a dozen countries, led by the George Institute, to use smartphones to collect data on what the packaged food, what's available in packaged foods in a particular country. And then subsequent rounds will look at unpackaged and street and restaurant foods by directly testing those foods. And then population surveys will ask people about knowledge, feasibility, acceptability, reach, and the short and medium terms effects of the shape components in 3 Nigerian states, the Federal Capital Territory, Ogun, and Kano states, to represent different regions in Nigeria. So some of our initial data that we've conducted key informant interviews and focus groups across 3 states with a variety of stakeholders at different levels, from the community all the way up to national policymakers. And the interview guides focus on knowledge and attitudes around salt intake, opinions and implementation outcomes for the 4 national multi-sectoral action plan, or the best buy strategies. And then we asked about barriers, facilitators, and context to implementation and adaptation. So some of the key barriers to the proposed strategies from the respondents are the customs and cultural taste for high salt diets. It does take time for people to change their taste for salt, but it can be done. Lack of awareness and low knowledge on risk and amount of salt in foods. Labels aren't routinely read because they're ambiguous and complex. There's easy accessibility and affordability of high salt diets. It's a flavor enhancer that obviously helps improve shelf stability as well. That's why it's used. And there's no existing school-based programs related to dietary sodium. So the environment isn't as supportive as maybe it could be. These are some of the retail survey data that are looking at how we've collected almost 8,000 packaged foods. So we have the largest food composition database in Nigeria that compares WHO benchmarks for different food categories, and looking at where Nigeria stacks up compared with South Africa. So for meat alternatives, and we have sodium content of milligrams per 100 grams on the x-axis. So for each of these categories, Nigeria exceeds the WHO benchmarks. So there is potential room for improvement. But we're also doing a dietary sources of sodium study using methods outlined by Lisa Harnack and colleagues from the University of Minnesota, who's a collaborator on this project. So we can see by asking people about potential sources of sodium, such as how much salt is added at the table, salt added during preparation, even testing how much salt's in water. In some parts of the world, it's saltier than you'd think. There is some sodium inherent in food. We're collecting the packaged food data that was just describing, and then even from things like supplements or antacids. And we're doing this, it's an add-on to the first quarter of 2022 STEP survey led by the Ministry of Health and the WHO. We're going to recruit 450 participants out of the 26,000 who will be recruited for STEPs from the 3 same states that we were talking about before. And we have trained certified dietitians who will collect 24-hour dietary recalls. And they're going to do 4 of these dietary recalls. And that's a reliable way to understand where the sources of sodium come from. And then we'll validate that actually with 24-hour urinary sodium collection. So whether or not those 4 best buy strategies are the right approach for a place like Nigeria is a little uncertain, actually. And we need to know where the sources of sodium come from. Because one of the potential strategies could be a salt substitute. This was a trial Bruce Neal published earlier this year in the New England Journal, testing the effect of a salt substitute that was 75% potassium and 25%, or 25% potassium, not 35, and 75% sodium chloride. This was in about almost 21,000 participants who had a history of stroke or elevated stroke risk, recruited from 60 villages in China. And the effect of the salt substitute that had a 14% lower risk of stroke, 12% lower risk of death, with no difference in hyperkalemia. So simply by giving a different sort of granulated white granular substance, swapping one out for the other, it reduced the risk of stroke and death. This is the cumulative incidence curve shown here. And the between group systolic blood pressure difference was 3.34. And that could be a combination of less sodium consumption, but also increased potassium consumption. So maybe salt substitutes are a better strategy in Nigeria. So the last piece, in just last few minutes, is just really the need and something that Victor and I have talked a lot about for training the next generation of global cardiovascular health and global health researchers. This is a list of my mentees over the past several years. Anuba Agarwal's a Northwestern instructor who's doing work on heart failure polypills and has a K99 NOA pending. Kavita Singh does cardiovascular disease secondary prevention quality improvement program. She was the first K43 awardee in India. Nilay Shah is doing a second generation South Asian cohort in Chicago with a K23. Salam is doing hypertension implementation research as a Wellcome DPT fellow. So it's just, hopefully you can see we need more people. The scale of this is really, really big. And it's been exciting to work with these incredible mentees over the past several years who are doing outstanding work, and I know are going to be leaders moving forward. Now, I also help with Northwestern's Global Health Fellows Program, or the Fogarty Fellowship that's led by Harvard, the HBNU program, as well as a co-PI with DK Oji and Lisa Hirschhorn for the Cardiovascular Research Training in Nigeria Research Training Grant. But I'm so excited to be coming to WashU and look at all of the training grants at WashU. I mean, so many. So I have so much to learn from people at WashU about how to do great training grants. I've been around for a really long time. I also helped co-lead and co-create the Emerging Leaders Program through the World Heart Federation, where we've trained more than 150 emerging leaders from more than 50 countries in implementation science, health systems, and health policy research since 2014. So it's been exciting to see some of the work that they've done be put into practice and have an impact on health policy. WashU has a real wealth of partners shown here on this figure that Victor shared with me. And we're going to need your help and hard work to be able to really bring this network together so that we can have these multilateral approaches to make our research more efficient, to make it reproducible, more robust, and more likely to have a sustained improvement in global cardiovascular health and healthcare. I do think there are major opportunities at WashU, and I want us to try and think about aligning with major global goals, such as the UN Sustainable Development Goals, the WHO Best Buys, as highly cost-effective strategies and programs, while also contextualizing to local needs, including what do we need in St. Louis? We need to integrate, harmonize, and support major global health research training, and educational activities to create a thriving global health environment at WashU, using a network-based approach among partners. We need to use open science principles to share and disseminate resources for not only faster and more equitable research, but also late-stage translation and research findings into routine practices and policies. And we need to leverage technology for multilingualism to meet partners where they are. So in summary, I'm so excited to join you in WashU in just a few months. And we've talked a lot about global cardiovascular disease and global cardiovascular health. And population growth and aging drive the large and growing CVD burden despite falling age-adjusted disease rates in most parts of the world. Unhealthy diets, air pollution, and high blood pressure threaten these gains. The direct and indirect effects of COVID-19 on CVD, among other conditions, expose major health system limitations and inequities that we must address moving forward. Cost-effective strategies exist across the spectrum of CVD prevention, but far greater investment, implementation, and political will are needed to achieve global goals. For every $1 invested in NCD prevention and control, $7 return on investment. This is an investment, not a cost. And great ideas come from everywhere. Will we be ready to receive, test, and accept new ideas, including from low and middle income countries? So I have so many people to thank at WashU, Northwestern, the George Institute, University of Abuja, Center for Chronic Disease Control, Cardiological Society of India, and my sponsors. I'll leave this slide up, and I appreciate your time and attention, and I look forward to any questions you might have. Thank you.
Dr. Huffman, thank you so much for a fantastic talk. Thank you for joining us today. Thank you for your work. We absolutely have a couple questions, though I know we're running just about short on time here. Our chair of cardiology, Dr. Prabhu, says, great talk. Can you comment on translating strategies to improve adherence and outcomes in LMIC to underserved regions here in the US and their anticipated impact?
Thanks, Sumant. Great question. So we've done a systematic review actually on strategies to improve adherence and secondary prevention, for example. And so we kind of have two buckets of things. We've got either health system level interventions. So you can have pharmacists, for example, supportive care. And that's clearly been demonstrated to be helpful. So Missouri has regulations that allow pharmacists to prescribe medicines under the supervision of a physician. So I do think that using non-physicians is a key strategy that should be part of how patients are cared for in St. Louis. Combination therapy has also been demonstrated to be able to improve adherence by about 40 to 50%. So it's not one or the other, it's both. That'd be my approach. Thanks.
Wonderful. And you commented a bit on this here at the end of your talk with opportunities here at WashU, but Dr. Maddox asks, what is a vision for your lines of inquiry when you start here? Maybe more specifically with some of this other work you're already doing, or you continue some of that while you're here?
So WashU is the coordinating center for the HLB Simple program, which is the integration of cardiovascular disease services and HIV care in low and middle income countries. Ken Sheckman is the lead PI for that. So that is a absolute treasure trove to be able to look at how to harmonize the data infrastructure across these studies, including some of the work that we've learned in Nigeria, but we want to learn as well, using common data elements so that the interoperability that we're talking about, how does the work that we do in Nigeria directly influence what's done in St. Louis, but also in Rwanda and South Africa and so on. So there are some playbooks out there, but they tend to be at a higher level. We need to have that interoperability on the data management, data infrastructure level. And I know that the data science at WashU is terrific. I'm very keen to learn more.
Fantastic. I wonder, just maybe as the last thing here, could you comment on the affordability of this poly pills? For instance, looking at our outpatient care clinics, the convenience of those often comes at a cost. Are these able to be affordable, and is that cost offset by that reduction in total pill burden?
Thanks. So many companies have differential pricing based upon per capita income for countries, for example. There is often not the appreciation of the potential cost of each of the drugs. People just say, what's my out-of-pocket cost? If you think about how antiretrovirals were scaled globally with major investments from the UN and related organizations, and there was a lot of bulk pre-purchasing to de-risk it for companies. So I do think there needs to be greater investments for this to actually work. Otherwise, it's just an idea. And that's not going to help our patients, I don't think. And combination therapy is really the standard for diseases like HIV that are chronic conditions. So to me, it makes a lot of sense, but we need to get more people to recognize what the upfront investments will need to be to make it actually happen.
Wonderful. Well, thank you again so much for being here. A big thank you to Dr. Davila and the whole Global Health Week. There's a lot of things still coming up. And thank you again for agreeing to meet with our recruits. There is the link in the chat, so please sign up for that and have the opportunity here to work with Dr. Huffman before he runs off to Nigeria later today. So once again, thank you so much for being here. We really do appreciate your time.
Thank you.
I'm going to throw up the QR code for everyone. Thank you so much.